and good morning. Good morning to our colleagues participating from other side of the Atlantic. And my name is Kazi Mohiul Islam. I am former Director General of DGFB Bangladesh. I welcome you all on behalf of the Public Health Cafe to the webinar Trend of Caesarean Section in Bangladesh. Where are we heading? You are aware that this webinar is organized in collaboration with the Department of Public Health, IUBAT, College of Nursing, IUBAT, Public Health Foundation, 𝗱𝗲𝗀𝗃𝗯𝗹 Hospital, Pakistan, and National Forum on Women's Health, Pakistan. And there is a Bangladeshi online organization that is Health Systems Matter, HSM. So these organizations are collaborating with Public Health Cafe. And we are happy to inform you that Honorable Vice Chancellor of IUBAT, Professor Dr. 𝗱𝗲𝗯𝗹𝗁, will chair this webinar. And we are honored to have two key presenters today. One is Professor Dr. John Richards. He is Professor of Public Policy in Simon Fraser University, Canada, and also Professor Dr. 𝗱𝗲𝗯𝗃. He is the chairman of Public Health Department, IUBAT. Today, in this webinar, we are extremely happy to have a number of nationally and internationally reputed panelists. And the panelists are would you please mute yourself who are not talking, who are not participating? Please mute yourself because the program is going on. So the panelists are Professor Dr. 𝗣𝗂𝗯𝗹𝗂 Islam. He is Director, National Institute of Preventive and Social Medicine, 𝗱𝗲𝗯 in Bangladesh. Professor Dr. Joe Thomas, Institute of Health Management, Victoria, Australia. Mr. Alex Barland, Health Systems Expert and Founder, Bangladesh Health Project, Canada. Professor Anwara Begum, former President of 𝗱𝗲𝗯𝗹𝗁 Gynecological Society of Bangladesh, and also former Chair, Obstetric and Gynecology, Bangladesh Medical University. Professor Sharmin Yasmin, Chairman, Public Health Foundation of Bangladesh, and Head of the Department of Community Medicine, Bangladesh Medical College. We are yet to see the participation of Professor 𝗱𝗲𝗃𝗀. Professor 𝗱𝗲𝗃𝗀 will be joining from Pakistan. He is the former president of Obstetrical and Gynecological Society of Pakistan and International Society of Obstetrical Fistula and Fistula Surgeons. So these are the panelists. Hopefully the other people, other participants will join. And besides the names I have mentioned, there are other participants, faculties of MPH, students of MPH, IUBAT. They are also participating in this webinar. I can see their names in the list. And we welcome you all, especially the students who have joined. Definitely it is a praiseworthy approach you have taken. You have allotted some time in the evening to listen to this issue because you have interest and inquisitiveness about the trend of C-section in Bangladesh, which is perhaps a significant public health issue. And for better time management, we'll try to keep our allocated time, like presentation for the keynote paper is 15 minutes, and rest of the participants who will be invited by me, they will get 5 minutes on an average to speak. And Honorable Vice Chancellor, sir, you will listen from you after the question and answer session, your concluding remarks. And the participants who have questions or some comments, they are requested to ask the question during question and answer session. Simultaneously, you can also post your question or comment in the comment box. So, may I have the honor to request Professor John Richards and Professor Dr. Nazmul to start their presentation on the key paper. Professor John and Professor Dr. Nazmul, over to you.
Dr. Nazmul has control of the computer and the deck. Nazmul.
Yes. John, 1 second, let me open the slide deck. Slideshow. Okay. Respected chairperson, respected moderator, sir, learned panelist, dear audience, it is our pleasure, great pleasure for John and me to present the key paper for this webinar today. That is on a trend of Caesarean section in Bangladesh. Where are we heading? John, would you please start? Yes, then I will follow you. Yeah.
We have been friends, Nazmul, for many, many years. And you have taught me a great deal about the complexities of Caesarean. My contribution to this deck and the work that we have done has been that, not that I'm a good statistician, but I could do basic regressions and organize some of that. I have a great respect for the interest that Nazmul has taken on this subject. The one question that I always ask myself, can we ever improve delivery without massive changes that increase the role of nurses, better training, more of them? Pakistan and Bangladesh stand out as the only countries in most developing countries in which there are more physicians than there are nurses. To you, Nazmul.
Okay, thank you, John. So yes, Caesarean section, the global scenario, it is gradually increasing globally. So in 2000, the global Caesarean section rate was 12.1%, and in 2015, it was 1.1%, almost double. So, this is 2015 data because, and I have taken it from Lancet Caesarean section series. And Lancet explained that, around 2015, the data, Caesarean data of most of the countries are available on that year. So they have compared the 15 data with the 15 years back, how the trend has been changed. And in 2015, there were 29.7 million Caesarean section globally. So that is in Bangla, it is almost 3 crore, Caesarean section. And it is estimated as, it is estimated that globally 6.2 million unnecessary Caesarean sections done annually. So how many of these unnecessary Caesarean sections are done in Bangladesh? So we'll discuss that later on. So John and I, we had a kind of observation 10 years back that the globally the iatrogenic fistula rate, it was changing. Yes, Sir, if you are not talking, kindly mute yourself, sir. Shasha sir, please mute yourself. Okay. So we found that the reason for female genital fistula, usually it was historically obstructed labor. Then we noticed that in many countries, more fistulas were caused by iatrogenic, surgical procedures, and perhaps because of the consequences of cesarean section. So we looked at data and we found, this is the data that you see, that the upper line, that is the Bangladesh, is the highest contributor in a kind of highest portion of iatrogenic fistula in Bangladesh, 40%. It was in 17-18 published data, and when we finish the project, at present it is 90% of all female genital fistula in Bangladesh are actually iatrogenic. So this is a slide actually prepared by John. John, do you like to talk about this great slide? Yes, please.
Sure. I mean, this is a very simple flow diagram. A family with a pregnant woman has got choices to make. Obviously, there's family at home and vaginal delivery. Or alternatively, in a facility, a hospital, or a private clinic. Now realize what we did here. NASML selected 15 villages. In all of these villages, we took every delivery in 2016. And this is the results of what we got. There were approximately half of the 500 were deliveries at home. In the hospitals, as you can see, approximately half of the deliveries in a hospital were 50%. In private clinics, it was 86%. Now, these are data that are obviously dated, 9 years. Now, the blue box in the middle is important. And we did a lot of qualitative discussion among the 500 deliveries. And, and what is important here is the extent of pressure placed on the family to transfer to a facility, which means almost certainly a cesarean. Now, there's a lot to be said in the blue box in the middle. There is unfortunately a lot of, to be honest, dishonest services from middlemen, from physicians who should not be undertaking cesareans. Excuse my voice. But I want to keep time going, so we can talk about it later, perhaps. On to you, Nazma.
Thank you, John. So, where we did the study in 2016 and found that, 86% cesarean section rate in clinics, in last July, we went back there and we found the cesarean section rate in those clinics now 97%. And the cesarean section rate in government hospital in that area is 71%. So there are many short-term effects of overuse of cesarean section and long-term use of long-term effects of overuse of cesarean section. The short-term effects are it increases maternal mortality in low resource setting. The odds ratio is 1.6 to 7.08. So up to 7 times it increases the risk compared to normal delivery in low resource setting. So that is, from this data, we can imagine that why the achievement in reducing maternal mortality in Bangladesh is why we failed to achieve the Millennium Development Goal in achieving the maternal mortality related benchmark, because perhaps of the very high cesarean section rate in the country. And there are severe acute maternal morbidities, and this morbidity could be used as proxy indicator for long-term consequences like hemorrhage, anesthetic complications, obstetric shock, cardiac arrest, acute renal failure, puerperal venous thromboembolism, infection, etc., etc. The neonatal outcome is very important in terms of, it requires more use of intensive care unit for the baby, and it increases mortality and morbidity for the newborn and respiratory illness, and it also impacts rate of breastfeeding. And the long-term effects of overuse of cesarean section, there are a lot of complications might happen in subsequent pregnancies. For example, risk of cesarean section in next pregnancy is obvious: infertility, preterm birth, mislocated placenta, ectopic pregnancy, uterine rupture, etc. And in long term, pelvic adhesions, small bowel obstruction, menorrhagia, dysmenorrhea, chronic pain, sexual dysfunction, incontinence, pelvic organ prolapse, and fistula. And for babies, the data are now coming, that is more metabolic syndrome, asthma, obesity, and allergy. So I'd like to spend some time on this slide. You see on the red line above, that is the institutional delivery rate, how it has been increased from 2000 to 2022 in Bangladesh. So institutional delivery rate is 65% in Bangladesh now. And in parallel, how the cesarean section rate has been increased. So what was 3% in 2000, and when the global caesar rate was 12%. Now, for example, in 2015, the global caesar rate was 21%, but Bangladesh caesar rate was 23%, and now it is, Bangladesh caesar rate is 45, it was a few years back. So this is actually tricky to understand this data. It means that from population perspective, 45%, meaning whole birth cohort when is the denominator. So if you consider it for hospital delivery only, institutional caesar rate, so it would be almost double. So you can imagine the cesarean section rate in Bangladesh institutions at present now around 90%. So I'd like to reflect on some fact and fantasies. We thought earlier that if we can increase antenatal care rate, the caesar rate will be reduced. Mother will be better counseled, they'll be better, for many reasons, they'll be prepared for normal delivery. Actually, that did not happen. We have found now that it is reported recently that high antenatal care rate, high elective caesar rate. So that is a kind of, something mystery, and this month, there is another report published from ICDDV. It shows that more availability of doctors, more caesar rate. So for example, in Khulna division, the more, the vacant position, the less number of vacant position is Khulna division, and the cesarean section is high. So why this mystery is, it is time to think back about, why it is happening. This is a kind of, infogram that it shows that cesarean section is an outcome of many, many factors. I'm not going to discuss this for the sake of time, but I'll share this slide with you after this presentation, and you will see that, it is not only a matter of doctors or the midwives or the patient party. There are many things related to health systems that contributes, the cesarean section rate. And there is reference of Robson classification. So my colleagues who are interested, they can also have a look about Robson classification, and you can also do a little bit of Google how Robson classification is being used in many parts of the world for addressing cesarean section problem. So I'd like to discuss now, a few points about related to health systems, health system related causes, about probable causes of that contributes in cesarean section. So perhaps the number one cause, what John was talking about, that is lack of midwifery practice environment and lack of adequate number of midwives. So that is one of the most important thing. And also doctor-nurse midwife ratio. In Bangladesh and in Pakistan, the doctor-nurse ratio is very different. We have more doctors than nurses, so that is something very interesting. And lack of skill and confidence of the doctors and providers for vaginal delivery, because the institutional delivery number, it has been reduced to, to very low, numbers. So the doctors and midwives, they're not getting opportunity to learn. And another thing is the doctors-led care, who are committed to many places and their convenience matters. So I think that might be an issue. And financial incentives for hospital and providers. And the last point is interesting, and I'd like to link it to John's point that most of the cesarean section cases are transferred to the facility during delivery. The commission provided for referrals to ambulance drivers, and that is actually paid immediately after reaching the clinic. So the clinic already paid the commission to the ambulance driver. So if they don't do the cesarean section now, who will compensate this money? So that's a kind of, that becomes the obligation for the clinic to do cesarean section to, so the commission paying to middlemen and others is an important issue. And the last point is very important, that is most hospitals don't keep record of indication of cesarean section or any data of cesarean section. So where are we heading to? Where this situation is taking us? So high Caesar rate actually is a barrier for reduction of maternal and neonatal mortality, and there are negative health consequences, impacting the quality of life of mother and children in long run. And the economic burden, increasing the out-of-pocket expenditure. You imagine that the out-of-pocket expenditure in Bangladesh is highest, perhaps one of the highest in the world. So about 70% of all the expenses, health-related expenses, we have to bear from our pocket. And catastrophic health expenditure, there is no data, but we can imagine that perhaps cesarean section is a cause of catastrophic health expenditure for many families. And because of lack of vaginal delivery in hospital, that I've explained before, that doctors and healthcare providers missing opportunities to learn and retain their skill for normal delivery, and unnecessary cesarean section. Professor 𝗱𝗁 is a great advocate of this, that it is a violation to women's rights. So what we can do to address this situation? I think availability of quality normal delivery service must be a prerequisite for allowing cesarean section in any facility in Bangladesh, along with 24/7 availability of midwives. And data for driving the change. I think facilities must show data. They are not sharing data, especially the private facilities, and they have to do it as per some classification, and they should be held responsible for explaining the rate of cesarean section. They must have to explain that why cesarean section rate in those clinics are 100%, 97%. And information sharing for demand side empowerment. I think that facilities, may show the cesarean section rate per month, what are the cesarean section rate in their facility, so that people understand, and it can be used for naming and shaming of particular facilities. And women, who will be requiring cesarean section, they must be informed about possible complication of seizure before taking their consent. And we think more well-trained midwives and nurses are needed for maternity care. Thank you. Thank you, sir. Over to you, moderator, sir.
Thank you very much, Professor John Richards and Professor 𝗱𝗲𝗯𝗹𝗶, for thought-provoking presentations. There are many questions. We have many questions in our mind, although we do not know answer to all of them. But by discussing all these things, maybe we'll learn, we'll share ideas, and we'll try to move towards our desired goal that unnecessary cesarean section will be reduced. Meanwhile, Professor 𝗱𝗫 Syed, he had joined, and I mentioned before that he is the former president of Obstetric and Gynecological Society of Pakistan and International Society of Obstetrical Fistula Surgeons. So he has been working on this for a long time, and he has a lot of interest, and he showed his interest to talk about all these issues in this webinar. So he will be requested later. And now I would request Professor Dr. 𝗍𝗂𝗧 from Institute of Health Management, Australia, and he is the former Executive Director of Partners in Population and Development. He was posted in Bangladesh for a long time. So, Professor 𝗍𝗂𝗧, you are requested to present your topic. It is Caesarean section, reflections from regional countries. Over to Dr. 𝗍𝗂𝗧.
Thank you, Mohidul Islam, sir. And let me thank and congratulate Professor Nazmul Huda and also the University of IUBAT. And I would like to give a public health perspective on C-section in the region. I would just focus on 5 points. One is C-section is increasing across the region, and the reasons I'll come to that. And I look at one of the major reasons is linked with the family planning practices. Inequity in the family planning burden is one of the factors, because in my fieldwork, what I notice is that C-section has got close association with tubectomies. The higher rate of tubectomy during the C-section, there's a relationship that is not explored much. So inequity in family planning access or the bias against women's involvement in family planning is one of the major reasons for the increasing C-section across the region. I'm noticing that. And also over-medicalizing the birth process. So what is this implication, cultural, social, professional issues involved in that? And also disrespectful maternity care. And many of the women, why they go for C-section? Because they don't know the alternatives. And increasingly in the maternity sector, the midwives are guided, or the role of midwives in the maternity care and the family planning is gradually reduced. In certain sector, there is no more midwives are being appointed. And in the popular parlor, we say that midwives are the one who handhold the mothers during the delivery. But if you expand a little more further, the midwives are the one who actually give the answer to the concerns of neonatal mothers, antenatal mothers. So when we remove the appointment of midwives, the support structure for antenatal mothers is removed. That has got, again, implication on a higher C-section rate. And one of the interventions we should look at across the region is promoting respectful maternity care. And respectful maternity care, information and informed choice is an important part of it. So any mother, neonatal mother, they should have the full information about what are the opportunities, what are the consequences of some of the procedure involved. And also what I notice is that the issue of post-surgical, the surgery site infection. And that's also I noticed that in most areas, post-surgical complications is increasing. In some setting, I noticed that it's about 44% of the prevalence rate is reported that the post-surgical, the clinical the consequences and complications. So, and finally, post-cesarean support provided through respectful maternity care, enforcing it through policies, political intervention, and also the political will of the government to come out with a protocol for promoting respectful maternity care. So in summary, the C-section is increasing. If I look at the case of Kerala, we notice that we call it as the epidemic of C-section. In some districts, it's 60% of all the deliveries are C-section, and I notice in Bangladesh, it goes up to 90%. So those phenomena, I should call it as the epidemic of C-section, unwanted C-section, and its implication. And also we look at the children's health, neonatal health, has got implication on the cesarean section. The children who are subjected to cesarean section has got a higher rate of diabetics and cardiovascular disease. So these are some of the observational data. There is a huge need for research and evidence-based data on looking at cesarean section. And most importantly, the indicator of the high level of cesarean section is an indication of the health system's strength and the health system's capacity. And also we should use it as a kind of indicator to look at the health system's reliability and validity to deal with the maternal health. And I summarize it saying that unwanted C-section is increasing across the region, and the regulatory mechanism to control and regulate is very minimal in most of the countries. And the professional competency to do natural childbirth is compromised, or many of the physicians are they're doubtful about their professional competency to do the natural childbirth. So this is a matter of training for the medical profession. And finally, we should use it as a kind of the health equity indicator. The extent of the greater number of C-section is an indication of a large level of health inequity. And I conclude saying thank you to the people who are organizing this. And it's an important initiative to look at health systems across the region and comparative data, and also the need for research to look at how to strengthen respectful maternity care. Thank you very much.
Thank you, Dr. 𝗂𝗂𝗧. Very, very valuable comments and remarks regarding C-section. And you rightly mentioned that the surgery site infection is one of the big problems.
Sir, unmute yourself, sir. Mayur, sir, unmute yourself. You're muted.
Okay. So thank you, 𝗂𝗂𝗧, for your thought-provoking deliberation. And you rightly mentioned that the surgery site infection is one of the big problems, and it's related to health equity issues. So thank you. And our students are being benefited definitely because of many medical and non-medical issues are being discussed. The students of MPH, definitely it will bring a lot of benefit for them. Meanwhile, some of the participants have joined later. For them, those who have joined, and you may have questions. Definitely, you have questions. Dr. Parnini from Ministry, she has joined. Brigadier Jamil has joined, and many of our colleagues have joined. So you may ask questions during the question and answer session, or you can leave your questions in the comment box. Maybe you have already got some answers to your questions, but Q&A session is for you, for everybody's question. So now, I would like to request Professor Dr. 𝗱𝗫 to give some lights on implications of high CS rate. Professor 𝗱𝗫.
Thank you very much for giving.
𝗱𝗫, sir, unmute yourself. You are muted, sir. 𝗱𝗫, sir.
Is it okay? Can you hear me?
Yes, sir. Now okay.
Yeah, we can hear you.
Thank you very much for giving me this chance to talk about epidemic of cesarean section, as it's mentioned by one of our colleagues from Canada. I will not take a lot of time, but I think increased cesarean section rate is direct violation of the woman right, especially in underdeveloped countries where the basic obstetrical care and emergency obstetrical care is not available. And I personally blame for the increasing cesarean section rate to the obstetrician and gynecologist and surgeons. To somehow, I feel that the last 30, 25 years, there is an organized campaign against the practice of midwifery. And I think wherever the midwifery of practice is compromised, section rate has increased. And Pakistan is one of the very good example where the midwives are not well trained, they are not competent, they are not empowered, and they are not skilled, and the obstetricians are practically working against them. There is a rumors that midwives are not trained person to deliver the babies. They are basically die, and die is a bad name. So I think in any country where midwifery practice is good, there will be a decrease cesarean section rate. I and many of our colleagues believe and think that women are not made to deliver babies abdominally. That's the reason we don't call cesarean section, we call it abnormal abdominal deliveries. I also blame surgeons because in most of the area where the qualified midwives and obstetricians are not available, most of the cases, some of the surgeons, general surgeons who are doing section just because they are working in some hospitals and it is convenient for them to do cesarean section, deliver the babies and charge their fee or whatever. I will just give you one example that in our center, where we deliver more than 14,000 deliveries per year, our section rate is very low in those people who are those women who are booked in our center. But our section rate increased because of the previous section rate section in different government and private hospital. And these poor girls come to our hospital because it's a free hospital and we have to do third, fourth, fifth repeat cesarean section. So in conclusion, I think section is a woman right violation, and obstetricians are failed to convince their patient that when they demand that they should have section, because this demand is directly reflect that the patient has no trust on obstetrician. Once the obstetrics was a art, and now we have lost this art and it's more dependent on the surgical intervention. So I think the cesarean section should be reduced with the campaign to increase number of midwives in our countries. Like in Pakistan, we need at least 400,000 midwives to run midwifery unit, and the labor room should be led by the midwife. If the midwife run labor room will started in different parts of the countries, there is a section rate very low. Just make a last point that in Pakistan, we have few centers in rural area where midwives run the labor ward, although obstetricians are there, but the cesarean section rate is less than 10 and 12%. So this is my few suggestions and points, and hope the panel will discuss in detail. And in future, we will fight against increased cesarean section rate, and we should have women with the normal delivery and normal vaginal delivery with good obstetrical care and good emergency care, and that will end up in a happy family with no scar on the tummy. And the last point I want to make, that one of our postgraduate students is doing one study in which she is trying to find out that the fear of pregnancy increase after normal vaginal delivery or the cesarean section. The initial reporting is that women, especially poor women who come to the hospital and have cesarean section, the fear of pregnancy increase and they don't want to become pregnant if there is a chance that they will have cesarean section. Thank you very much.
Thank you. Thank you very much, Professor Shersha Soyed. You really highlighted very, very important things which will be discussed and raised question by others as well. And now I would like to request Alex Barland. He is the health systems expert from Canada, and he is also founder of Bangladesh Health Project Canada. So, Mr. Alex Barland, you are requested to talk on turning the tide of C-section trend. Is it possible? So we are eager to hear from you. Is it really possible? Alex Barland.
Thanks, Mohil. Hello, everyone. It's nice to see you. Is it possible? Well, I'm an optimist. So yes, of course I'm going to say I would like to think it's possible, but as we've heard, it's very challenging. It's very difficult. And my focus is health human resources. And so I think about supply and demand issues. But first of all, I want to refer to one of the slides that Nazmul showed, the infographic, which showed how complex this problem is. And it's very typical of these complex problems that they affect many, many parts of society, as well as the healthcare system, as well as health human resources. So I believe that we have to take a complex systems approach to analyze the problem in order to find ways to tackle the problem. There is no single simple solution. There are some very important components. We've heard about the role of midwifery, the role of expectations, the standards that are required, the need for data. These are all very important, and in the context of a systems perspective, those are probably the areas that we want to focus on first. I want to keep my comments brief because I believe the question and answer will be very important. Let me say a couple of words about supply and demand. The supply issue is really, as we've heard a lot, role of the providers. And this is an area where the APEX professional group, the Society of Obstetricians and Gynecologists in their various forms in different countries, that those professional societies play such an important leadership role. So I think that's a critical part of tackling the issue. With that leadership in place, different solutions are possible. Without that leadership, the leadership from the professional groups, and I would include the groups of in Bangladesh, the Council of Nurses and Midwives, the other professional associations, I would include all of those groups in finding a way forward. Unfortunately, as we know in Bangladesh, there's a lot of competition amongst the professional groups. There's rivalry. There's long-standing historical conflict. And there has to be a way through that problem in order to have a unified voice for better services. It's so positive and encouraging to me to hear the other speakers talk about respect for human rights, respect for the women's rights, the equity and ethical issues behind this. And I believe that's fundamental to all of the professional groups. So when we talk about leadership, I think we have to start by talking about our ethical responsibilities. I think people go into these professions because they want to make a positive difference. And I think if we can reach out to them, maybe it is possible to get through the history of competition and rivalry amongst these groups. So that's first and foremost. There has to be political will at the professional level, political will at the government level. Yes, maybe, but I think if the professionals wanted to make a change here, it would be possible. On the supply side, from an HHR perspective, clearly we need to rethink the role of providers, what the providers are doing. And I use three things that I think need to happen. One of them is upskilling, making sure that all of the people involved in the birth process have the skills that they need, and recognizing they're probably very focused in their work. We're not talking about a very large range of skills. The Robson classification, for instance, some of these things are quite narrowly focused. It's not a very, very big job to make sure everybody is fully up to date on the standards and expectations. We need to do some downshifting. In other words, transferring duties from more highly skilled providers, more scarce providers, to other kinds of workers. And we need to do some cross-training so that surgeons understand what OBGYNs do, what nurse midwives do, what nurses do, what midwives do, and other kinds of workers in the system, so that there's good understanding and there's opportunity to transfer the skills. On the demand side, this is something I know I really can't say very much about. Childbirth, the entire process of reproduction, is one of the most complex socio-cultural aspects of any society. And this is something where it's Bangladeshis will have to decide for themselves how best to communicate with other Bangladeshis, women, and especially the male decision makers. We haven't talked about the role of men. It's the special interest of one of our IUBAT students doing his research overseas. What is the role of men in making decisions for women's childbirth experience? So I think the demand side stuff, back to you folks to think about. Data, been mentioned several times. This is something that can be done with allies, colleagues outside of the professional realm. We can go to information scientists, NPH graduates, and other kinds of analysts who can help us create the data that we need to identify where the problems are, find places where we may have a little bit of opportunity to make a change, and also, of course, to look at progress and see where we're being successful. I'm going to stop there. Those are my focus areas. I want to close by saying leadership is essential. Leadership is the only thing that is going to make it possible, to answer your question, Mohil, to make it possible only through professional leadership of all of the professions involved in the childbirth process. OBGYN, midwifery first and foremost, but also general practice, antenatal care, nurses, surgeons, sometimes general practitioners, leadership amongst those groups. That's all.
Thank you, Alex. It was brief, but very resourceful speech. And you have rightly mentioned that the political will is so important, so very important for bringing change in the C-section activities. And also the role of male, that is an area where we have to work hard. While I was Director General in the family planning, we also found that males think that family planning things these are the women issues, not the male issues. So male people, they used to avoid and turn their backs to all these initiatives. So now we'll listen from Professor Dr. 𝗣𝗂𝗯𝗹𝗂. He is the Director of National Institute of Preventive and Social Medicine, NIPSOM. He will speak on research needs for optimizing CS rates. Research needs. So over to Professor Dr. 𝗣𝗂𝗯𝗹𝗂.
Hello, everyone. Assalamu alaikum. Thank you very much, Qazi Mohibul Islam. Really, I'm pleased, and it's a great pleasure of having here as a panelist. So I'd like to express my thanks to the organizer of IUBAT. So far, it's an established fact that Caesarean section is a surgical procedure which is related to the life and death of mother and newborn. So far, the evidence shows that Caesarean section may be of different types. It may be clinical, non-clinical, sometimes elective, sometimes emergency-based. However, the statistics or data shows that it was around 2.9% of Caesarean section took place in Bangladesh in 1999, whereas it was 18% in 2011. And it is now 45% in 2022-23. And around 18% Caesarean section took place in public health facilities or government health facilities, whereas around 83% it took place in private hospitals. So based on these realities, we need some diverse research. Actually, we need real data on cesarean section. And if we want to make a national database on cesarean section and its realities, we need comprehensive research works. I'd like to say I have learned a lot of things from the previous speakers. And it is evident that I'd like to focus on some research priority areas to control or to reshape these uprising cesarean section rates. First of all, we have to carry out some researches on magnitude of cesarean section in the context of Bangladesh. Magnitude may be in terms of type of caesar section, the health facilities performing, their nature, geographical variations, socioeconomic factors related to or cultural factors related to this cesarean section. A lot of things we can do under the headings of this magnitude of the problem. And what is the real rates throughout the country? And we can do some researches on determinants of cesarean sections or influencing factors. This may be socio-cultural or economic factors, or it may be related with the awareness of the demand side peoples, that is the pregnant women, their male partners, and their families. And there are two paradoxes, too many and too few paradox. The rich peoples or women are using more, the poor people are using less. What are the stories behind it? It should be unmasked or unveiled in the context of Bangladesh. And we can do some researches on economic aspects or impacts of research, impacts of CS. And the data revealed till now, it shows that average cesarean section expenditure, out-of-pocket expenditure is around 23,000 taka per woman or per cesarean section. And around 67% of these expenditures are cost of total delivery. And around 7% of this cesarean section expenditure bears 7% of total healthcare expenditures per capita. So we have to find out the real picture or economic consequences of cesarean section and its catastrophic impact on the families. There are huge scope to carry out research on the economic dimensions of research. Another crucial area I'd like to say, we have to carry out some researches on health impacts of cesarean section. As it is mentioned that cesarean section has impacts, long-term and short-term impacts. That long-term and short-term impacts, I don't know Bangladesh have that real database or not. I believe that it is the high time to do some cesarean section cohort study. We have to develop some CS cohort, and that cohort may be pregnant women cohort and the newborn cohort. We have to follow up and we have to find out prospectively what happens to them, to mothers, to their newborn babies. It's really scarce in our context. Not only that, Nazmul and other speakers have said that there are a lot of health impacts. I will not go in details. That could be explored in details and in a pragmatic way. And I'd like to say research regarding some health system related issues considering cesarean section. It is evident that the cesarean section is taking more in the private sectors. But the question is why it is taking more in private sectors or private hospitals. Are there any ethical violation? Are there any impact of referral system and monetary benefit to the people like village doctors or like some ambulance drivers or other healthcare workforce? And what are the ethical issues and what are the conflict of interest in respect of healthcare delivery system? At the same time, we have to evaluate the existing health facilities in primary, secondary, and tertiary level. What is the doctor population ratio? What are the supply side capacity for cesarean section and NBD or normal delivery? And what are the standards and quality of service they are performing? There are huge areas of potential research works. and already mentioned by Nazmul, we can do some Robson classification-based tracking system we can incorporate in the context of Bangladesh. Moreover, I believe that we have a lot of lackings in documentation of data related to Caesarean section. That's why we need to do some research regarding clinical audit system, good governance, and quality of Caesarean sections. And finally, I'd like to say that Bangladesh especially demands evidence-based Caesarean section guidelines that should be followed by all the healthcare providers in private and in government, in NGO health facilities. So we need comprehensive countrywide research. What are the determinants behind it? And what are the consequences of Caesarean section in terms of health and economic? And what is the best practice? And what is the clinical governance? Finally, a dynamic research process can offer clinical guidelines and Caesarean section guidelines for the country. This is about from my part. Thanks for your patience, participation, and hearing. Thank you all.
Thank you, Professor Jia. Yes, I agree that you have rightly mentioned that we do not have authentic data, and for any decision, data-driven decision, we need actual data. And during my long service in the health ministry, I found that the research side is one of the most neglected side. We do not put much attention towards allocating budget for research, but we need to conduct researches so that we can find out the true or core causes of these kind of problems. So thank you, Professor Jia. Now I would like to request Professor Anwara Begum, the former president of OGSB. Professor Anwara Begum, you are requested to speak on the role of professional societies in rationalization of CS rate. Over to Professor Anwara Begum.
Thank you. Assalamu alaikum to everybody. Thank you very much for inviting me to such an important meeting. So in fact, I am from Obstetrical and Gynecological Society of Bangladesh, that is a professional body. This Obstetrical and Gynecological Society thinks that it is very worrying that we Bangladesh is having such a high rate of cesarean section, and the OGSB is very much concerned about it. So we do have a subcommittee who are working on this only, how we can reduce the cesarean section rate. So these subcommittees and others members of the OGSB, they are working along with the government and other development partners to find out what are the causes of the high cesarean section rate and how can we decrease the cesarean section rate. And one of this is that they have developed the labor room protocol where there is respectful, it is very important that respectful maternity care and all those other care so that the cesarean section rate we can decrease. And they are very much involved in implementing this respectful maternity care, which we are calling labor room guide protocol, and it is adopting in every facilities of Bangladesh, and OGSB is very much involved in implementing these facilities in different parts of the Bangladesh. Another important cause of cesarean section is history of previous cesarean section. So this OGSB, they have made a standard protocol for vaginal birth after cesarean section, VEBAC, so that we can reduce the cesarean section rates. And we are distributing this, disseminating the knowledge of these protocols and supplying these protocols to different facilities and also giving them the training for these facilities. One of the important thing is the pain during the labor, especially those who are from the affluent societies and who are having deliveries in the clinics and private hospitals. They, in fact, they themselves want to have cesarean section because of the pain. So, but in Bangladesh, you know that the most effective measure to reduce the pain is epidural anesthesia, which is very available, is very few. So we are working along with the other society like anesthesiology society to find out how can we increase the epidural analgesia and the availability of an epidural analgesia to all the facilities. In fact, it is very few, only a few hospitals, private hospitals have got this analgesia. Again, another important is the non-availability of the midwifery. For last few years, the OGSB and government and non-government and development partners, they are involved in giving training to the midwives, and OGSB is very much involved of giving training to these midwives. They are going to their field work, they are going to the field and seeing what are the problems they are facing and how can they improve that facilities. They are going to the fields, and in fact, they are making them learn how to do these things and overcome these problems in facilities. And another important is about options classifications. These options classification, if we can group the women who are having the cesarean section in options classifications, then we can understand what is the most important cause of cesarean section and what is the least important cause of cesarean section, and what are the cesarean section, why the cesarean section is different in different facilities, so that we can find out that if there is cesarean section is high in previous cesarean section in that facilities, we can go and they tell them how we can do the VBAC, that is vaginal delivery after cesarean sections. And again, if the cesarean section is more in case of nulliparous women, primary nulliparous women who are having artist presentations and spontaneous labor or induced labor, why it is increased and how can we reduce it. And about the pain, though there is very few centers who have the epidural analgesia, but the other non-pharmacologic agents and pharmacologic agents, how we can help the people, women, to have these agents and have the vaginal part. And it is really important that we should talk to during the antenatal period, we should talk to the patients, that is the women, about the labor, process of the labor, what is the pain, how can you reduce the pains. There are different non-pharmacological agents also that by which we can reduce the pain, different types of exercise, the sitting position, the different types of position during the delivery. All these things will help in reducing the pain and having a large number of cesarean sections. Another important thing is fear of litigation. Sometimes, after normal, though we are all talking about that we should have much more vaginal deliveries, but there is a question. Sometimes, the baby might have some problem during vaginal delivery or even if during cesarean section. But if it is during cesarean section, a baby after cesarean section is having respiratory distress or something like that, then the parties does not blame the doctors. They think the doctors have done their worst, but it is our luck. But if it is following vaginal delivery, then they will say, why you didn't do the cesarean section? If you have done the cesarean section, then the baby will not have suffered this problem like this and that. So we'll have to talk about all these things to the people, even during the antenatal period. If we discuss all these problems to the patient and also the family members, then I think they will be more eager to have the vaginal delivery, and we can have we can reduce the cesarean section rate in this way. So I think the OGSB is doing different works along with to reduce the cesarean section, along with the development partners. They are developing, disseminating, and promoting evidence-based clinical guidelines, protocols, flowcharts for safe maternal care. They are also working, giving training and having mentorship and collaborative efforts with the government and development partners. They are standardizing the clinical practice to improve the healthcare providers' skills and encourage the respectful, effective, normal delivery practice to reduce the high and unnecessary cesarean section rates. Thank you.
Okay, thank you very much. Thank you very much, Professor Anwara Begum. You mentioned the respectful maternity care. That is very important thing. And last but not the least is Professor Sharmin Yasmin. We are shortage of time, so would you please finish your speech within 2 minutes. Professor Sharmin Yasmin, role of Bangladesh Public Health Foundation for optimizing CS rate. I would appreciate if you. Thank you.
Thank you for inviting me here in this very august gathering on this very important topic. So I will try to squeeze my comments. And many of my contents of my talking already been mentioned by my previous speakers. So we saw that we have a high rise of C-section in our country, and multiple factors are associated with this high trend related to patient and caregivers, related to healthcare providers, condition of the health facilities and their limited resources, and also transition of the socio-demographic patterns of the two-party and also the regulatory approaches that we currently have in our country. So we know that Professor Zia already mentioned that before policy development, we need to have a very good evidence-based information. And in Bangladesh, we have scarcity of this information. We have less actually documentation of data. So, and we also have some of the causes and impacts of unnecessary C-section. And one thing I would like to add that was missed here about the impacts of unnecessary C-section on the baby is that in some of the studies, it was found that some of the delayed development and also sensory integration problems are associated with unnecessary C-section. So it is a very alarming actually condition for the future of the baby. And Professor Zia rightly mentioned that cohort 2 be studied for the next 4 years from the time of pregnancy or after delivery, both the mothers and for the babies. So what we need now, we need to have a collaborative effort from every key player in this field. And one of the important enabling factor for this is to create a level playing field. So level playing field is not only applicable for political field, it is also applicable for here, because starting from the political leader, social leader, and all our regulatory authority and other stakeholders, patients, care providers, they all need to be oriented with the same regulation that is prevailing within the country to achieve the targeted goal. That means to reduce the unnecessary and irrational C-section, and to also undertake the very skilled NVD by the midwives and other medical professionals. So in this connection, I would like to share that in October 2023, High Court directed the government to take steps to make it compulsory for all hospitals and clinics to follow the relevant guidance to prevent unnecessary and irrational C-section. And Ministry of Health formulated a guideline in 2019 under the title Bangladesh National Guidelines and Technical Standards and Operating Procedure for Promotion of NVD and Prevention of Unnecessary C-section. The guideline recommended to develop and launch a campaign to raise awareness on harmful effects of unnecessary C-section, and it suggested to enhance NVD skills and competencies of midwives and to review existing law, rules and procedure to identify the weakness and propose modification to ensure the right of the patients, caregivers, etc. So here it is very important that every of our panelists mentioned about the need of midwives in required numbers. So in our country, the number is 2,500, but our demand is 22,000. So here is the gap. And midwifery is a bachelor's degree, a degree of 4 years. And if we can recognize them with respect in all the facilities to handle the NVDs, and also to be acquainted with the referral system for the complicated cases, I think the unnecessary C-section could be prevented. And in this context, all the regulatory bodies with concerned stakeholders should exchange dialogue for policy development, and Public Health Foundation may facilitate dialogue on CS rates and program development. And now I would like to talk about some crucial gap in the maternity cycle. Do you have any scope or program for preparing the expecting mother for normal delivery if she undergoes safe pregnancy? No. Do we make her physically, mentally, and socially ready and make her empowered for NVD? No. Do we educate them about the painless NVD by epidural? Already Professor Anwar Madam said the practice of epidural anesthesia for painless NVD, but it is not practiced. About 30 years back, many of my relatives, it was introduced in Bangladesh in many hospitals, the epidural anesthesia. But why it is not that much practice? What is the reason behind that? We must explore it. So it is also, I think, the attitudinal problem with the health professionals lie behind the unnecessary C-section also. So it is one of the causes among the many of the causes. So during antenatal period, pregnant women should take the right decision by patient empowerment. And for that, we need to educate the mother. And this is one of the weaknesses need to be rectified. In the intranatal care, do we have enough midwives that I already have mentioned? If we see countries like Sri Lanka, Nepal, Vietnam, Thailand, they are conducting the NVDs with the skilled midwives. So we can do like that. So I think it is the proper time to think about that. So considering the physical and financial burdens of unnecessary CS and evidence-based recommendations to change the scenario in Bangladesh, like one I have told you that we have to remodify the regulatory strategy regarding the unnecessary C-section. That is important. And we have to improve the healthcare facilities. We have to provide, we have now unskilled healthcare workers. We have to change it, and we have to proportionately give the manpowers within these facilities. So we must make a forward-looking vision to overcome this situation from now on. And Professor Alex, you have said that responsible medical leadership, I really appreciate it. Leadership is very important. Apart from political leadership, gynecological societies and obstetrical societies can lead the pioneer leadership in our country, and side by side, other associations could be co-opted with them. And tracking and reporting on the monthly rate of unnecessary C-section, Professor Zia properly mentioned that. So these are the important points, and database development in all the delivery facilities, it is very important. And also the medical audits and community level awareness program for proper sensitization of the mothers and families to continue and enhance their knowledge. So the patient, we know that in the medical ethics, one of the important principles is autonomy. So it is patient's choice, but patient choice when the patient know about the pros and cons of the C-section. So we must actually consider all these issues for creating a regulatory approach and strategic approaches for C-section prevention, which are unnecessary and irrational. So if we can get time in the question answer session, maybe I can contribute more. So thank you so much for giving me the opportunity. Thank you.
Thank you very much, Professor Sharmin. You mentioned that the government has made guidelines and rules and for promoting NVD. Actually, we are very good at formulation of policies and making rules and laws, but we are very weak in implementation. So there, you rightly mentioned that we need to implement those rules and guidelines. And another thing you mentioned, that the education is very important. There is no medicine like education. So we have to educate our people, our mothers, our caregivers, all. So we are at the end of the speech part, and I have noticed that most of the questions, those were put in the chat box, have been answered. So, and we are running behind the schedule. So if you have one or two very vital and important questions, you may please raise. And after that, our Honorable Vice Chancellor, sir, he will give his concluding remarks. If you have any important and very pressing question, you can ask.
Sir, can I say something, if you would
Oh,
allow
yes,
me.
Dr.
Ms.
Parnini, Dr. Parnini from Health
Yeah,
Ministry.
thank you for giving me the opportunity. Can you hear me, sir?
Yes. We hear
Okay.
you.
Sir, well, I must congratulate the presenters and also the speakers, because they have really spoken a lot of things about Caesarean, the increasing Caesarean, activities in Bangladesh. But what's actually going on? Because there is, of course, supply side and demand side, and we belong to supply side because I belong to the Ministry of Health and Family Welfare. So Bangladeshi government has taken a lot of initiatives regarding compliance, regarding regulatory mechanisms. But well, we have formulated strategies, and we have our health policy, which would be revised soon, and we are going to really have our Health Security Act forthcoming. So a regulatory framework is also being developed by the ministry to reduce actually this kind of Caesarean practice in Bangladesh, and to encourage patients and all the people in Bangladesh to go for a normal delivery. But well, I went to just last week, went to Chittagong for inspection of the hospitals as well as the nursing colleges. So what I saw, the real picture is really gloomy, because we observed that the clinics, private clinics, are mushrooming. Like, I can't really imagine that the clinics are just beside the hospitals and health complexes. Even in the periphery, the clinics are just mushrooming without license, without compliance, and having their section for Caesarean babies and Caesarean. The people are there, the patient and the health professionals. Those who don't have any license, they are operating this kind of Caesarean, this kind of surgery. So what government is doing? Although we are going for inspection of hospitals, and we have actually developed guidelines for the midwives and also for nurses and health professionals, but those are not being implemented. When we went for inspection, we saw that clear violation of all the rules and regulations being formulated by the Ministry of Health. So it's pretty clear for us, but we can't take any actions because, well, sometimes they say that when we actually go there, they said, well, they are going to do everything what we recommended, but afterwards they don't actually do anything, and we don't have any mechanism to really go for impunity or to punish them for any violation of compliance or violation of rules and regulations, because enforcement is really weak in our country, as Mohib sir mentioned. But I have actually heard about the system of Australian health policy and also Pakistan and different scholars. So we have learned a lot of things from their practices. And of course, everybody is talking about to improve the health system as a whole and to do research, to focus on research and development. But what about actually the brokers, especially when the patients are going to public hospitals or public or any kind of health complexes? The ultrasonography is not working. The machine, the X-ray machine is not working. These are all, made non-functional. And what is happening? Those patients are going to the nearby clinics, and the doctors and the health professionals working in the public hospitals getting salary from the government. But what they are doing, they are just making every machine out of order, and they send most of the patients to the nearby clinic, and thereby and when they go to the private clinic, the doctors in there actually suggest the patients to go for this kind of C-section surgery, without knowing the post-surgery complications. And it actually makes this kind of Caesarean actually activities are causing health hazards for the woman forever. So, but people are not aware of that. So this kind of paradox
this kind of complicacy and this kind of relationship, how can we really mitigate these challenges forthcoming? So in the years to come, we are actually trying to focus on the compliance issues, the governance issues, ethical practices, and also the regulations and rules and regulations which should be enforced practically. And we are now visiting in our field, in our facilities, because we also deal with the family planning directorates, where we have our FWC, where actually because Mehul sir knows well, because he was actually the DG of family planning. We have our family welfare center, where lots of workers, especially the female workers, are going door to door to make aware of the pregnant mothers that, well, this kind of Caesarean C-section is really bad for the health, and it would actually cause disability for the women who actually would go for any kind of Caesarean activity. So normal delivery is really good for health and for baby and for mothers. So that's how we try to actually encourage family FWA. We have our FWV, so family welfare centers. We are encourage the workers of those centers to go to door, and so this is their additional work. We are really putting emphasis on those workers' activities and those workers to really make aware of the of this situation, especially how Caesarean or the C-section is causing disability to the women. So awareness buildup is very important, and compliance issues when we go to really go for inspection of hospitals and college and also other institutions and health facilities. We are trying to motivate the doctors, the health professionals, not to really send the patients to the nearby clinics. And we try to make all the machineries functional. We are putting lots of budget to those health facilities from the ministry to really make everything in order, so that the patients, especially the people who are living below the poverty line, BPL, they could really be able to come to the facilities and get free treatment and get diagnostics, free diagnostics, because we have our essential service package where we could really provide that. So those are the things actually I have mentioned, because we have really learned a lot of things, but practically many paradoxes are there which we have to actually think of.
Yeah.
Thank you very much. Thanks for giving me the opportunity to say something about this. Okay, that's all.
Thank you, Dr. Borneni. We appreciate your concern, and you are in the ministry, so you can also take care of many of the questions you raised. So now I have the honor to request the Honorable Vice Chancellor, Professor Dr. Abdul Rauf, to give his concluding remarks and any observation. So over to you. Thank you.
Thank you. Well, respected participants of this wonderful webinar, I have been listening to the presentations. Many of them are technical ones. I am a student of management, not of your profession, but I had an interest in knowing about this, because I found casually that many people are going for cesarean without trying the normal natural delivery. Now, the deliberations have pointed out a number of causes and problems, and they have also tried to come out with some suggestions. My observation is that we must see who is the decision maker of whether this should be the normal delivery or a cesarean section. And who are the people influencing his decision? Is it the family members, or are these the health professionals, and so on? If you ask a village woman, she might not know the merits and demerits of cesarean section and the merits and demerits of the natural delivery. Well, we might look back, say, some 30, 40 years ago, when we had very little facility in the district or levels below for any cesarean section. So almost all the deliveries would be natural ones. But there was risk. So the mortality rate, child mortality was high. Well, someone might argue that it is not just the delivery problem, but it is also the patient's health conditions and other things. Well, if I leave this aside, I would say this child mortality rate has come down. Okay, so some might say it is due to the cesarean section, that no risk is being taken, etc. But as I found today from your discussion, that, well, this is also a lot of risk and so on. So let us find out people who are really influencing the decisions and try to influence them to give the patient the right suggestion. That might start from the health worker, who are actually guiding and advising the pregnant women, particularly in the rural areas. And then the doctors, certainly, unfortunately, the doctors are the ones who would prefer cesarean than going for natural delivery. That is where a very critical problem arises. So, and then I would say the other thing also, the trained midwife are decreasing in number because they don't have much of this job. And that perhaps that will be another cause for not going for normal delivery. So the issue of research has come up, and very interesting, that we don't know many important issues at all about this cesarean. We need a lot of research. And who are going to do this? Well, certainly government should have some fund. Research can be conducted by the universities or other research institutions under the grant of the fund from the government. But I'd say also the universities, they can also earmark some fund for particularly these issues. So given all these things, I think we had a very lively discussion session, presentation session. I like to thank the Public Health Cafe team for hosting this webinar, a topic of significant public health interest. Thanks to the collaborative partner of the webinar, Health Systems Matter, Public Health Foundation of Bangladesh, 𝗱𝗲𝗯𝗹𝗂𝗀𝗋 Hospital, National Forum on Women's Health, Pakistan, Department of Nursing and Department of Public Health, IUBAT. Their joint efforts have resulted into today's session. But I must thank Mr. 𝗱𝗲𝗯𝗹𝗂𝗀𝗋, moderator, Professor John Richards and Professor Nazmul Huda, key paper presenters, and panelist, Professor Dr. Ziaul Islam, Director of the National Institute of Preventive and Social Medicine, Professor Dr. Joe Thomas, Institute of Health Management, Victoria, Australia, Professor Sher Syed, former President, Obstetrical and Gynecological Society of Pakistan, Mr. Alex Barnard, health system expert and founder, Bangladesh Health Project Canada, Professor Anwar Begum, the famous obstetric gynecological expert and also former president, Professor Sharmin Yasmin, Chairman of Public Health Foundation of Bangladesh. As we said, trends of cesarean section, where are we heading? We understand by now that we are heading towards a disaster rather than a safe delivery system. Then that's why it is urgent that we take actions. And quite interesting that there are rules, laws, and regulations. Despite these things are happening. And the presenter on this, she rightly pointed out, it is because just in other cases in Bangladesh, there are laws, there are rules, regulations, but there is no monitoring and penalizing system. So that will be going unabated. But then most alarming situation is that these sections are being done by private clinics with much less specialization and expertise in the job itself. And that needs to be curbed immediately. And that is the part of the government's job. So let me thank every one of you, including those who joined as an audience. We had for some, it was an educating session. For some, perhaps a direction to take action, and also for some to attend the research and other things. Thank you, everyone, once again. Allah Hafiz.
I must congratulate all the participants for their patience and for their interest. Maybe after this program, we'll be thinking time and again that what is the biggest challenge in addressing the rising of C-section. Inshallah, we'll be meeting soon again with you all, maybe with some different burning question. Till then, Allah Hafiz, stay well. Thank you very much. Assalamu alaikum. Good evening, good night, good morning. Thank you.
Walaikum assalam.